Good afternoon, everybody. I'm Chris Gudas, and am a OTP medical director and addiction doc across 4 county jails. And today I'm going to be presenting with Dr. Freidman about some recent developments about what's happening behind the wall. This was actually rearranged, and it comes on the heels of a great talk. Thank you. Because if you think there's challenges in rural Vermont, let me tell you about the jail. So I know we're not supposed to talk about ourselves, but I want to quickly run through my background. Again, I'm currently working across 4 OTPs, each with different arrangements with vendors and working for the county directly. In that capacity, I've also had an opportunity to work with the Federal Bureau of Prisons and a reentry linkage to care through the Coolidge House. So I have familiarity with how that system works indirectly. We've also been able to, in partnership with Spectrum, set up an addiction medicine fellowship program for their hospital addiction medicine program to try to bring fellows behind the wall to see what's going on there. And I think that's really important, like conferences like this, to teach people what's happening there. We're also in the process with Dr. Freidman on working on an investigation to long-acting injectables, even though this is a methadone conference, in the pretrial population, which at the end of this talk, hopefully you'll see is of critical importance. We've also worked on bridge clinics, previous outpatient, inpatient settings, and in-home addiction treatment. So I'm really interested in kind of the avant-garde or the fringes of where treatment's provided. Peter and I have anything to disclose, and the goals of today's talk is to review the criminal justice system structure. I was dissuaded from trying to do this, but I think even in the jails where I work, there's a lack of understanding about how the jails and prisons work. And so I want to take our time to make sure that we understand how the system works, to understand where we can provide care. I'm going to review the established benefit of MOUD, which I think most of you guys know. Dr. Freidman's going to review some of the J-Coin research in the pilot program in Massachusetts. And then I'm going to circle back and talk about some of the kind of actual nuts and bolts about what that means in terms of implementing these in the jail. So in terms of organization, when you get committed of a crime, counties, of which there's over 3,100 in this country, 14 in Massachusetts, 12 if you don't count the islands of Martha's Vineyard and Nantucket, hold detainees while they're awaiting trial. If they're sentenced to a crime, they can spend up to 2.5 years in a house of correction, which is also operated by one of those county entities. Now, those can run concurrent, and people who are in jail or pretrial awaiting major trials can sometimes sit in jail for times longer than 2.5 years as well. When the sentences are longer than 2.5 years, inmates are sent to prison for longer term sentencing. But there's also important consideration around the federal system. And federal detainees are moved across prisons around the country and are held pretrial in county jails. So we actually have overlap with some federal detainees as well. There's also Immigration and Customs Enforcement Agency detainees, a majority of which are actually subcontracted to private vendors and to counties. So many people are surprised to know that in this state, we actually house ICE detainees. So these are individuals that are picked up elsewhere, shipped here for housing, and then often deported. And if we have time, I'd really like to talk about what that means with regards to MOUD and methadone, because we're seeing it now. In a picture form, this is what it looks like. You get arrested, you go to jail. Now, I wanted to talk for 20 minutes about the history of jails, and I have been dissuaded from that too, but I'll give you a 30-second blurb. Traditionally, jails were intended to just house you temporarily before they decided what to do with you. So in early colonial times, that meant you got stuck in a room until they put you in the stockade or whipped you. They were not intended as facilities to offer anything in terms of treatment nor rehabilitation. If you go to court or trial and then you release from there, piece of cake. If not, and you get sentenced to a minor detention, you come back to the House of Correction. Now, these two entities do not necessarily have to be the same physical space. In this county in Middlesex, up until 10 years ago, there was actually a jail on the 17th floor of a high-rise in Cambridge and a House of Correction in Billerica, which meant moving patients back and forth. In Suffolk County right now, there's still a separate jail and House of Correction, Nashua Street and South Bay. At one point in time, over the last 5 years, those two entities actually had separate vendors and medical records. So that has huge implications in terms of complexity. Imagine working in a hospital and admitting somebody through the emergency department to the floor where they used a different medical record and different staff. Then they released and came back to the ER and they had no access to that without requesting it. So there's huge complexity that goes into this. And again, a point on the jail is that these were not entities designed to provide treatment. In Essex County, there was the Salem jail that in 1991 was replaced with the current facility, and there was no running water. So inmates were given a chamber pot and a bucket of water each day in 1991. So for longer sentences, people go to prison. And traditionally, those are places where there's more services. There's services for education, for providing medical care, and for a clear picture on when they're going to leave at the end of that sentence. As we mentioned, also the federal systems involving the ICE detainees and federal prisoners. I think most people know that in this country, we're really good at incarceration. We have 5% of the world's population and 20% of its incarcerated people. A lot of people have heard that statistic. But if you look at this, you can see there's actually a decline, in particular in the incarcerated population, even pre-COVID. How do we do in Massachusetts? Well, this is important. We actually have the lowest incarceration rate of anywhere in the country, 116 people per 100,000. Some states in the South have almost 5 times that, which equates to almost 1% of their population. How much does that cost? Well, on average, this estimates, as of 2023, with inflation-adjusted dollars, the country spends about $65,000 per inmate per year. About a third of that's healthcare. Some states in the South spend less than $30,000, and we spend more than twice as much as any other state at an estimated $307,000 per inmate per year. So there's a bunch of things that go into this. Part of it is that we're shrinking that prison system, as I mentioned, and while it shrinks, there's still the infrastructure in terms of buildings and staff with less inmates. The other is that if you offer programming and you provide care, then people don't come back. And Europe's already shown that in terms of providing services so that you don't have to pay for the same inmate twice. I always have to throw this in there that we're also pretty good at spending money on K through 12 education, the top 10 at less than $20,000 per year. So we have about 1.9 million people incarcerated in this country right now. 5 years ago, that was 2.3. But more critically, almost 5 million have previously been incarcerated, and 113 million people have an immediate family member who's been to jail or prison. So even if your patients don't go to jail or prison, they likely have family members that do. And so it's critical that you understand how this thing works. Here's a graphic showing that breakdown. Overall, that 1.9 million people, about a third are in the jail system. And this is probably the most important slide of the first part of the talk. If you look even over the last 25 years, the increase in population at the county level has been in the jail or pretrial population. That means people who are not convicted yet. And that's largely because they can't afford the bail to be able to release, and there's huge implications with that. Health in jails and prisons. So we all know why we're doing this, and I'm going to race through this to save more time at the end. These patients are sick, right? And it's not just from drug use. There's a 12-time more likelihood chance of these individuals dying in the first 2 weeks post-release. Now, overdose leaves the risk of causes, but it's also chronic health conditions, homicide, suicide as well. And you can see that that risk decreases over time. So the point of highest risk is actually when they're being released from jail. In Massachusetts, that risk starts to fall, and you can see then it makes obvious sense that we should prioritize the point of reentry. Also worth considering why people go to jail. About a third of the reasons they're there for crimes related to drugs and alcohol. But if you look at other causes like violent crime and theft, a majority of those crimes are substance involved. So it's my non-biased opinion that a majority of the purpose of jails is to address the results of drug use. This is an old slide, and 10 years almost, and it uses words like heroin, but you can see that there's a proportional relationship between opioid use and criminal legal involvement. So it's almost the natural cause for progressive use to result in involvement with these systems. And so it seems to me that it should be the likely place to prioritize treatment. I'm going to pass the microphone to Dr. Freidman to talk about some of the statistics, and I'll circle back to talk more about jails after.
Good afternoon. Yeah, he'll be back. He'll be back. He'll be back. I know you're applying for me. So thank you. So I'm Pete Freidman, the Chief Research Officer at Bay State Health, and I'm an immediate past president of MASAM. So I'm going to just talk a little bit about some of the work that we've been doing, looking at outcomes in the jails here. But first, just a little bit of the evidence for the effectiveness of MOUD during incarceration. Most of the prior work has been retrospective pre-post designs. There was a prominent one from our neighbor to the south in Rhode Island, which showed that of those who died of an overdose in 2016-17, they had implemented all 3 FDA-approved MOUDs. You can see that 60% of what they were providing was in fact methadone. And they showed a substantial decrease in mortality well, they showed a decrease in community overdoses that were related to incarceration. So it's sort of like a case control type design with what they called a relative risk of of 0.4, so a 60% reduction, which was actually very similar to what they showed in other data from California in 20 and 21. Interesting studies, not designs that had some issues. We actually looked at our experience in Franklin County compared to Hampshire in a natural experiment from 2015 to 2018, looking at recidivism. 197 individuals received MOUD, primarily buprenorphine in Franklin, and 272 in Hampshire County who did not. And we followed them up over 1 to 4 years and looked at recidivism and mortality. We didn't show a benefit in this study in terms of mortality, but we were able to show that there was a for those who did not receive for those who did not receive MOUD, there was about a 1.5 times increase in recidivism. And this was also borne out similarly around arraignment. Again, primarily a white population, a white male population in those counties. What was sort of interesting is that a lot of the effects on recidivism, some of it was related to drug-related crime, but a lot of it, of course, was related to property crime, which is sort of what you might expect. So we set out with the legislative mandate in 2018 called the CARE Act. It created Massachusetts Chapter 208, and that required a pilot in jails in Massachusetts, sites that agreed to be part of this, to provide all FDA-approved forms of MOUD no later than September of 2019. They were required to provide medication maintenance at intake and then induction within 30 days of release. It included the 7 county jails in red in this were included in the pilot. And we got funding from the National Institute on Drug Abuse to do a type 1 hybrid effectiveness implementation study. I'm going to primarily today talk about our AIM-1, which was a longitudinal treatment outcome study, sort of looking at the effectiveness of the MOUD on outcomes. But we have a number of papers about looking at the implementation experience. There's some work on the costs and economic evaluation, and then we've recently started some work following folks up to sort of see some of the outcomes that we were not able to get from administrative data. So these were 7 jails, or as we heard, houses of corrections. And we enrolled folks who had what we called probable OUD, and I'll explain why we had to use that definition. These were folks who were enrolled between September of 2019 and December of 2020. That's a time period that I'm sure is near and dear to many of you, but it was sort of like right at the time that COVID, was kicking up, and those who exited before July of 2021. So they had to have had 180 days of post-release follow-up. There were about 6,400 jailed persons, about 2,700 received MOUD, and when the facility, and about another 3,600 did not. And we had to define probable MOUD because each of the jails, there's a saying, if you've seen one jail, you've seen one jail. Each of them, there's really not reliable screening in many of the facilities. Sort of someone came in withdrawal, they'd get started if somebody said that they'd been on it. So you can see from the 7 jails the different ways that folks in those facilities determined who had probable OUD. So self-reports recent use on a medical or a mental health intake, or screened using the TCU drug screen, self-report or using the DAST, urine screen if they came back positive or they had an assessment during mental health. And some facilities, we couldn't really determine how they did it at all, and we had to use something we call the PhD algorithm, which I'll talk about in a second. So there was a lot of variability in terms of who got treated. Um, the data, the source of data for this is the Public Health Data Warehouse. And for those of you who are not familiar, this is a very unique resource we have in Massachusetts. Applause to our colleagues at Department of Public Health and BSAS. This is a linked data set across multiple domains. It's built on the all-payer claims data, so all the medical claims, but they link all kinds of other death records and BSAS treatment matrix, which is the ED runs and all these other kinds of things. The jail data had been sort of difficult to get. The jails are sort of a fiefdom unto themselves. And I think one of the things that we were able to contribute was to put staffing actually into each of the jails to help them sort of jumpstart them to be able to collect some data, to be able to look at this. The OUD algorithm uses this DPH public health data warehouse to find indicators of opioid use before the index jail intake, and looks at 3 types of historical indicators: an indicator of overdose, an indicator of opioid abuse or dependence. I mean, most of it was DSM-3 or 4, and an indicator of MOUD treatment. So there were a number of things that we were able to use to look at their prior experience. So we're really interested in post-release MOUD treatment. Were they actually more likely to link to care? Was there an impact on reincarceration, overdose, non-fatal and fatal, and all-cause mortality? And we used a method called propensity score weighting to adjust for selection effects. So whether or not someone got treated, this was the pilot, not everyone got treated, and whether or not someone was treated is not a random event. So to sort of make it more closer to a randomized trial, you use methods like propensity weighting is one of them. And what we saw at baseline was there really was not much difference in age or sex in terms of who got MOUD and who didn't. But there were, substantial differences in terms of race. So Black, non-Hispanic individuals were much less likely to receive MOUD. There were differences in terms of pre-incarceration overdose, higher rates in the MOUD group. In keeping with the criteria that had been set out in the pilots, 72% of those in the MOUD group had been on it prior to admission versus 17% in the non-MOUD group. And in keeping with what it takes to, to do assessments and get people started, there was a much higher proportion of folks who were sentenced in the MOUD group than in the non-MOUD group. And in keeping with that, higher number of days incarcerated. So we needed to adjust for all of those things. And that's sort of what this figure shows, is that the blue dot shows the imbalances across these variables when you don't do the weighting. And then the red dots shows what happens is when we did the weighting, you can see it goes back towards 0, which suggests that it did a pretty good job in balancing the 2 groups. So what did we find? Those who were treated with MOUD in jail had a 3-fold greater odds of linkage to community MOUD in the first 30 days. It's about 3.2. And lower odds of reincarceration, a relative risk of 0.88, which is about a 12% reduction, and a lower odds of any overdose, 0.55, so almost a halving of any overdose. We didn't see, because of relatively small numbers and non-fatal overdoses in this group, we didn't, there was a pretty wide confidence interval. There was a suggestion that 0.83, but it crossed it crossed 1, so not a positive effect. However, when you look at all-cause mortality, sort of speaking to what Christopher was talking about before, about all the various causes of death, we showed really a halving, a 0.48 hazard of all-cause mortality as an impact of the treatment. A number of limitations. I talked about the identification of the non-MOUD arm. Since there wasn't sort of regular screening, it really was not standardized. So we did do sensitivity analyses using the OUD algorithm for everyone and showed very similar effects. There is varied MOUD access in the communities, and really, I think a lot of the disparities we saw in the jails probably reflect what's happening in the communities. Because if you come in on MOUD, you're having gotten it in the community, you're more likely to start it in the jail. So we're going to need to look at that much more closely. There are some data quality and matching challenges. We really the privacy issues around the data are quite strict, and so the analysts really can't go in and do cleaning to see, or do validity work around the data. And then, this was during the midst of the pandemic, which might have distorted our outcomes. That said, we are waiting for later years data to be able to look at this. But I'm pretty comfortable, given all the noise and everything else in the data set, to say that jail-based MAUD treatment, of which about 55% of it was methadone, is associated with post-release linkage in the community, a decrease in total overdose, decrease in reincarceration, and decrease in all-cause mortality. And these racial and ethnic differences that we saw clearly merit more examination and intervention going forward. I just want to acknowledge a cast of thousands, my colleagues at DPH, our colleagues from the correctional facilities, and our research staff. So I will stop there and pass it back to Christopher.
Thank you. So I think before I go further, though, most people in this room know that these tools work. And it's pretty commonsensical to know that if we apply these tools in a high-risk environment, they're going to work well. The bigger issue is, again, just understanding kind of the landscape. And sheriff's departments are run by elected officials that have a criminal legal background. They're not looking for evidence-based experts, subject matter experts to build their healthcare systems, right? So that only comes when two things happen. One, research shows them that these things work and they get excited about expanding them. And two, litigation. So it was mentioned earlier about the CARES Act, and that's kind of where I entered this equation. During COVID, I started at 2 that became 4 county jails. And then Governor Baker signed into effect a push to expand MOUD in emergency departments, Section 35 facilities, and the 5 county jails that were mentioned. Now, right around the same time, there was a suit that was mentioned earlier today against the sheriff of Essex County for an individual that was on methadone, that was about to be incarcerated, and was expecting the usual care, which was then to medically supervise withdrawal and provide injectable naltrexone upon release. And the results of that lawsuit showed, thanks to the help of expert testimony of people in this room, that that is not the standard of care, as we know. And so 2 more counties decided to join that pilot program. Essex and Suffolk County joined. So the 7 counties that you see are there, along with the DOC. Berkshire County, I believe, was also providing the services, but not in the study. So what you see is a big division between parts of the state that were enthusiastic about expanding these things and those that were not. And I've had the benefit of working in both environments, both those that were early to adopt and those that got forced to do so. So I like my infographics. And again, to make clear, through that process of incarceration, pretrial detention in a jail, court, and sentencing, what the pilot program said is if you come in, you can continue on anything you want. And the criteria for that varied by location and by time. When I showed up, you had to have, for example, an active prescription within the last 2 weeks, I believe. And it's expanded to an expiration of 30 days after the last prescription, with an assumption that people may be extending their medication. Methadone poses other problems in terms of last dose verification and what we're allowed to do in terms of continuing them versus starting them. What the pilot program also did is ensure that people who came into the system and then were sentenced could be started on the modality of their choice 30 days before they went home. That didn't protect for the jail population, which, as we already talked about, are the highest risk cohort. So here's that division. You can see as of 2019, where you went to jail dictated what services you were offered. And I think most community providers don't even realize this. And it's true even still till today, because after this, there was push. I should say, I forgot to, I kind of glazed over the Pesci case, but the big argument was that it's a protection under the American with Disabilities Act. So if you are stable in treatment with these tools, they can't take them away from you. However, if you're using illegal drugs, then they're not entitled to provide you with those. And so those same arguments were extended statewide, and there was pressure for everybody in the state to comply. So that still means, though, that if you come in on those treatments, you'll be continued throughout. If you don't, there's still at least 2 counties where you're not provided anything. Here's just kind of a summary of my involvement, again, starting on the North Shore in Essex and Middlesex County, where the intention was to actually partner with an outside vendor who knew their stuff with regards to things like OTPs, and to open an OTP based on that expertise in the county. They each chose different strategies. In Essex County, we actually did establish an OTP and then opened our own to have the flexibility of being able to control policy. In Middlesex, that was the original intention, and it shifted to partnership with an outside OTP to provide those services. I was also involved in Bristol County, which the prior sheriff swore he would never offer MAT, and then when it was recognized that it was coming, actually opened the doors wide open to provide services there. And I've also been involved with Plymouth County, the last of the 14 counties to offer these services. And each one has applied a different strategy in terms of how they do it. So those strategies include, like I said, opening your own OTP. That's what Franklin County did as the OG back in 2016. And it's a lot of work to kind of pass the administrative hurdles. But once you do, you have the flexibility of controlling your own OTP. The other is that you can partner with an outside vendor to either bring medicines in every day or transport inmates to an outside OTP, which was happening as recently as last year, or they can establish a satellite for their own OTP. Now, there's advantages and disadvantages of both. There's continuity of care. So if you're part of an OTP system that has a network of community OTPs, there's much easier segue of services to those community OTPs. When we first started, there were reported cases of some OTPs that didn't want to receive our patients because they were from jail, high risk, and there was no OTP to return them to because the only OTP was in the jail. Also during COVID, there were sometimes medication shortages. And if you're in a network of other OTPs, you can share that supply. Whereas if you're your own OTP from a state pharmacy, you're SOL. There's also redundancy of EMRs. So if you're using another OTP, they have by requirement either SMART or Methasoft, and that's different usually than the medical record that's being used inside the jail. Advantages and disadvantages of both. Another important point is that when an OTP enters a jail, it's often an entity apart. And so by that I mean it's just like the community where OTPs are not providing the general medical care, and in some senses and in some instances, there are physically different buildings where these services are provided from the medical departments within the jail. Dr. Freidman was nice enough to share with me some data that he's working on with Ryan et al. About a cost analysis of what's happened in Massachusetts too. And that compares opening your own OTP versus partnering with other people. And it looks like probably the most cost effective is to open your own OTP. But what this slide doesn't show is that there's at least 2 counties that partnered with a vendor and then decided to open their own OTP. And having seen many iterations of this, I think there's actually some advantages to that, because when you entrust an entity that is not a healthcare provider to use these medicines without the expertise, I think there's some pitfalls. So here's some considerations, and we'll see how many I have time to get through before I get the hook. Access to the MOUD is variable. If there's one thing I want you to take home, it's that your patients are not guaranteed the same treatment in every county. And that's evolving. I think this is necessary. And I think it's the first step for kind of promulgating this throughout the correctional system. Staffing is extremely challenging. One thing I can't understate is over the last 4 years, how hard it's been to retain staff in this environment. And there's a whole talk's worth of what those are, but I just want to touch on a couple of the big points. One, these are largely pre-contemplative patients, right? These are not people that are seeking services. Oftentimes they've never sought services, and they often have other real complex medical comorbidities and behavioral concerns. Also, for the staff that works there, it's a ripe opportunity to provide treatment in a insulated space, right? Patients never don't show up. You can see them the next day. You have continuity of care. But the best behavioral interventions that are offered and the relationships that are forged are cut short when people go home. And I also want to touch on the point of how that relates to methadone, because I don't want to forget this point later if I get cut off, which is the folks that start methadone in jails often have no familiarity with what it means to be in an OTP. So you, as medical directors who receive these patients, may have patients that up until you see them have been handed their methadone outside their cell for the last 6 months. And they don't understand the infrastructure that we've been talking about today and the obstacles that are required for them to get their next dose. There's also a question of what does it mean to bring these 3 modalities into a jail? And in preparation for this talk, I've been thinking about this a lot. And it's really kind of crazy. Outside of maybe some places like Brightview, there's a few places where all of these are offered together, right? And I always tell patients that in the community, they're somewhat like car dealerships. A Ford dealership's going to try to sell you a Ford. Toyota dealership's going to try to sell you a Toyota, but they don't have the other cars to offer. And so they're going to steer you towards that modality. And though we have all these pitfalls and problems, we have a wonderful luxury that we're able to quickly change modalities and help people. So that means somebody who's actively using, they can't get back onto BUP, as was mentioned earlier today, and are on the methadone clinic, we can switch them. Somebody who's never been successful on buprenorphine, and we get that out of their history and assessment, we can get them on methadone and on a stable dose before they go home, right? The rare person who wants to transition to Vivitrol, we can help with that. And there's a whole lot to talk about long-acting injectable buprenorphine for another talk. Diversion. This is the hot topic in every jail. And when you introduce these things into a jail, you create an incentive to try to divert that medication if you're differentially offering it to patients within that environment. And so you can imagine in sites that I was at where patients in a dorm setting were the first Suboxone or methadone patient, and the officer said, "Sign for your Suboxone," and they had to walk through a dorm full of violent offenders and return after being dosed. There's huge incentive for them to break the rules and try to bring it back. And there's huge ingenuity in terms of how they do that. Using cotton, there's a infrastructure of selling these medicines, and that infrastructure often involves monies exchanged outside of jail. So cash apps and families that exchange those monies, and only indirectly through interaction with security, there are huge amounts of money spent on this, which makes some of the prescribers, in effect, participants. Also, there's ingenuity when you restrict access in kind of profound ways. So different jails have tried different strategies for how best to control this diversion. One has been to put everybody in the same unit, which makes sense as a treatment unit where you can provide behavioral services. But one thing you can see on the bottom here is in a jail where we were doing that, an inmate who was removed from the program because of their activities was able to use fishing lines made from sheets with hooks to create a communication between neighboring floors to transfer drugs and supplies. And so the first person in that jail to figure this out was somebody with extensive carceral experience, and did it because they wanted their medicine in a unit where they weren't allowed to get it. And that resulted in everybody else learning how to do it. So the take home is that you can invest effort in trying to control this medication in that environment, but it's impossible to do so. And what it does is create a false economy that you then participate in. I also want to say there are drugs in jail. And when you talk to people, depending on who you talk to, they'll say, "There's no drugs in jail." Or some inmates will say, "There's all the drugs in the world in the jail." But it's actually more dangerous because it's a mixture of the two. The drugs that come into the jail do so unpredictably. So there are people, like we're talking about missed days and whether you're using fentanyl. These are people who maybe do not have a tolerance, and now somebody comes in with a bolus of fentanyl. And the reasons for that are multiple. One is if you're in the street and you're fearful that you might go to jail or prison and you get arrested, you're going to swallow the medicine. You're going to swallow it because traditionally these programs didn't offer services and you want to self-medicate. You're going to swallow it because you don't have the money to pay for things while you're there, or food or canteen. You're going to do it because it turns out the prosecution for the offense of having it is less while you're in the jail than it is on the street. So there's even an incentive if you don't want to bring it in to bring it in. So there are also not drugs in jail. And what I mean by that is that as an OTP within this entity, we are separate from medical, and we cannot inform their decisions on what they do for their medical policies. So imagine a patient that, whether you agree with it or not, is prescribed their Xanax, their stimulant, and their gabapentin from a psychiatrist for 10 years. All those get stopped, and then you meet with them. And if they're stable on methadone, the one lever they can pull is you. But if you assist them with that, and some of those symptoms can overlap with cows, you're now setting them up with a higher dependency, and they're going to return to a medicine cabinet that's filled with those drugs. So there's nuances in terms of how we treat patients because we can't treat them holistically in many ways like in a community OTP. I just want to talk about correction officers. So it's a very different treatment milieu than in any other setting I've ever been, because these are not healthcare professionals, right? These are people who have traditionally been tasked with rehabilitation, but that rehabilitation comes back to a legal offense, which if you go back in the history of jail was a moral offense, and the intention is that they have to pay that back through their time in a cell. So there is a huge cultural shift in terms of educating the correctional staff about what we do. And what I've seen is that unfortunately, sometimes the jails can't assign the people that are most interested because it's a democracy. So sometimes you're working with partners that are opposed to what you do. And we've seen that as an opportunity to actually educate. And so by educating the officers on why we do, I've seen several times people that work with us regularly become or move from critics to the biggest champions. But then unfortunately their shift changes and you get a new person who starts all over again, and you have to start that process all over again. They also have probably the hardest job in the world. And I took out slides, but the health statistics for correctional officers is that their life expectancy is 57 years old nationwide. Their substance use and suicide rate is astronomically higher than the general population. So this is not an environment like anything else outside of the walls. Outcomes are also often unknown. So I think the importance of research, like we were talking about, is one, so that the public can know the benefits. But I think we know that from other states and from earlier efforts in the western part of the state. Bigger issue is to create an incentive for these jails to perpetuate the services and expand them to more people. So I talk fast, but I want to leave time for questions. I just want to share one thing though, which was I was thinking on the ride in today, and it was just compounded by the talks, about how much I'm reminded of buprenorphine 22 years ago. And I may not look it, but 20 years ago, as a medical student, I spent time with some of the doctors who had their first waiver for 30 patients. And I remember interviewing patients and them hearing about this late great thing, Suboxone, that my friend has. And I would take their history and present it to the attending. And they'd say, yeah, it'll be about a 6-month wait until we have a slot open for the 30 Suboxone patients. It took 20 years for us to get rid of the DEX waiver to allow more liberal prescribing of that. But I'm now faced with the same thing where I meet patients and I'm not able to offer them services because of the logistics of having to roll this out. And that's too bad. So we got time for questions.
Hello, I'm MASAM Lee. I'm from Mass General, Charlestown Community Health Center, Inpatient Addiction Consult Service, Medical Education with Residents. I actually just have two fairly concrete questions in that I have many patients who move in and out. And I think one of our horrible challenges in primary care in our field are the silos and this black area where nobody knows what's going on. Two things that I've heard and I've been experiencing, patients tell me that they, when I prescribe them 24, even 32 milligrams, and they must get dropped to 16 milligrams. They can only get 16 milligrams. And the other thing I've been encountering a lot in my clinic, we're getting a lot of patients onto long-acting injectable. They love it. I work with a slightly more stable population now than I did before. And so many folks on long-acting, if they have court cases, they fear that because they have long-acting injectable and they're told, and they tell them, I have Sublocade in my system, then they don't get it. And then they just don't get it when they go. So curious about both dosing changes and what you're doing with folks who, with their injectables aren't necessarily seen in, PDMPs.
Sure. So I'll start in the reverse order. First with the long-acting injectables, because I get really excited about that. So at two of our sites, we've actually rolled out long-acting injectables. And so for anybody who comes in on one, as you know, the PMP is not reflective of them getting it. So there are both instances of it being in the PMP and them not getting it, and them getting it and it not being in the PMP. So our standard procedure is that they tell us they've gotten it, we verify it with somebody who's given it to them regardless. So they're continued on that regardless. The good news is anybody who comes in now is guaranteed to basically do so. I agree with you. I think there's huge benefits with the long-acting injectable. Interestingly, and I should have probably gone into more depth, but we oftentimes consider kind of levels of care. So if you are having trouble with the Suboxone because of the dose or the frequency with which we're giving it to you, we move to a higher level of care. And by trouble, I mean we can offer you methadone, or if you violate the program rules, you'll be offered that or terminated. And so I think one of the big problems is that as an OTP with limited staff, we have to wait and watch these people dissolve. In many ways, it's kind of like the reverse of the community. This is another thing I was thinking today. you think about a methadone clinic, you have to figure out, until we have more liberalization, MOUD, et cetera, how to get to the clinic every day, or at least you did up until recently, right? In the jail, we bring it to you every day. In the community, we give you a prescription for Suboxone by telemedicine for 30 days. In the jail, we watch you take it every day and crush it, and you have to spend 10 minutes taking it the way that we tell you to. So unfortunately, I think most of the patients that I've seen that are on higher doses end up splitting their dose. And so a problem is that no amount of medication in a single daily dose is going to approximate that, which brings us back to the long-acting injectables. That solves the problem, right? The other issue is about interoperability, right? So I'm not supposed to talk about specifics, but I've talked to the state pharmacists, and there's 2 counties that prescribe higher doses, most don't. And so if everybody is on the same dose and patients move between those or the Department of Corrections, it doesn't create a situation where people's doses are cut in high-risk environments. The other is that when we experimented with increasing doses, everybody went to that dose. And it's really hard to kind of make an assessment for that. So if we allow higher ceilings, everybody leaves on that ceiling. And the problem is I can't guarantee who the receiving prescriber is, because some prescribers, even that I work with across other HOCs, in the beginning wouldn't prescribe more than 8 milligrams. You look at the package insert and the prescribing instructions, and it says that that's wrong, but they didn't believe that 8 was more than appropriate. I can't persuade them, right? So the interoperability is part of it, but the long-acting injectables, I think, solves an even bigger piece. I hope that answered the question a little bit.
So Chris, Peter, thank you so much. You guys are like my heroes. Kind of a comment and a question. One of the things that I argued back in 2018 was that opioid agonists, especially methadone, I felt not only prevents overdose, but prevents suicide. Did you see, now that you're doing, having worked in different counties with various level of interest and giving MOUDs, what are your thoughts on that? Have you seen, because for example, like Bristol County, right? It's one of the last counties, right? Weren't they cited for having a suicide rate that was 3 times, the national average?
They were.
I mean, again, there's confounding factors here, but what are your thoughts on this?
Absolutely reduces suicide, right? And there's instances, both before my time and during, where individuals that weren't provided, access to these treatments have resulted in death.
Yeah.
So, but I want to actually bring a counterpoint to what you were saying too, and give both sides of the equation. At Essex County, which we were talking about, when all the modalities were open, they were actually aggressively administering Vivitrol at great cost. So the thing is, it's not that they were malicious. I think that they were misguided. And that only changes through education.
Well, the company got in trouble for that. They were using the wheels.
So remember,
They got in trouble for that.
but remember, they're only certain, the suicide rate would be for people who are coming in on it, who are forcibly withdrawn, right? Clearly that there would be a benefit there, but there are a lot of the counties still that are not doing induction, for folks who are coming in on street fentanyl or street heroin or whatever it is. They're not doing inductions right away for a lot of the facilities. There are ones that are doing it, like Franklin and others, that are showing real benefits in terms of behavioral effects inside the facility. And so our hope is that, to Christopher's point, we're sort of at the beginning of this, that as there's more experience, they'll be doing earlier inductions. I mean, I'm hoping we're going to get to the point that everybody with an opiate use disorder, the day they come in, they will get started. That's really the direction that we're hoping that this will go. We're not quite there yet, but you're absolutely right. It would decrease suicidal ideation, fighting, violence, all kinds of things like that.
Do you think it's the NMDA antagonism? Do you think that's the sort of like ketamine?
I just think it's
I think
it's just the irritability.
sick.
It's the irritability of being in withdrawal, and you have someone else who's getting the med and you're not. So strong arming, things like that that goes on to because you're desperate.
Thank you.
Real quick, I want to make one more counterpoint too, because I want to try to convey as much as I can to community prescribers. And I just want to make clear something that also happens in jails and prisons, which is individuals who don't want to be on methadone leave on methadone. So there are instances where people that can't take Suboxone, either because of dose or frequency or behavioral issues or diversion are offered methadone or nothing. And so they choose methadone as the last resort. And so I want you guys to be clear as prescribers of both buprenorphine and methadone that you may be receiving patients post-release that don't want to be on that modality. And you have to help navigate them through the Bernice method or switching them. And OTPs are not well equipped for that because many of them want to keep you on the methadone and don't give you the full flexibility. So I'm really excited to hear that community providers are doing that. Recovery Connection didn't do so well as a company, but they actually were miraculously good at receiving patients on methadone that wanted to switch. And though they couldn't co-prescribe, they could communicate with the OTPs to prescribe the buprenorphine in collaboration. Todd.
Todd Kerensky, South Shore Health, Spectrum Weymouth OTP. A few of the things that I was going to ask were just recently said. I'm not sure this is going to result in a question, but I just wanted to thank, it's not a question, but it is important. So first of all, I want to thank both of you. Excellent talk. And I consider myself honored to know both of you and consider you friends. So thank you for your expertise and what you do in these settings. It's meaningful. My statement is this. To Peter, I think that the science is settled. I think everybody in the room can agree on that. But what we need is implementation science. And the reason for that is because when I was asked for part of Healing Community Studies to give a talk where, as you know, I presented your prior research and I presented basically the same slides. This is a true story. The sheriff walked out in the middle and the people that remained booed me at the end. So the science is not good enough. And I don't know if that's Chris's point here today, but I think it's the point that we need to figure out.
So science is necessary, but not sufficient. You know, we have a whole second aim around the implementation and some of the challenges of the implementation. You know, success is its own reinforcer, right? I'm sure Ruth and others have experienced, you know, medical providers and correctional security and correctional folks and medical providers who have been resistant to this, but after they see the effects on the behavioral effects within the facility, the effects on outcomes, those attitudes change. So really it's sort of the getting that started. So how you create these networks. I mean, one of the things that we've been fortunate in Massachusetts, it was sort of ingenious, you know, we created these pilots and now we have a cohort of folks who've had success doing it. And then they can work with the later adopters around how to do this, you know, without having to reinvent the wheel. So yeah, you got to get started somewhere. But yeah, I agree with you. The data are very compelling. And I also think the experience is very compelling. And so once you start doing it, then others will see that. And that's really why I think we're moving in the right direction.
Yeah, and you know, I could think about data around other topics too. So for example, when you look at data surrounding family contact and incarceration, you reduce family contact, you get worse behavior in the jail and higher recidivism. During COVID, when that was made virtual versus in-person meetings versus a virtual encounter, I'm sorry, made virtual instead of in-person, behavior got worse, recidivism went up. So I think the one thing that those sheriffs are interested in is the data in terms of recidivism, in terms of their performance, right? Most of these counties have programs. They try all kinds of things, right? They try therapy dogs, they try different reentry strategies. And I don't want to be cynical, but in many ways, they're kind of like restaurants. 9 out of 10 fail. They, I think, view these programs in some ways, or they did in the beginning, like a restaurant, not a medical service line, because they're not hospitals and they're not physicians. So I think the data is important to support that, but I agree with you that the implementation is the hard part. The other part I'll say is that they resist change in specific ways. And so they have I think a habit of removing those things that are threats to the way that they usually do things. And so changes have to come kind of incrementally, otherwise the wall comes down.
Hi, everyone. I'm Bridget Volk. I'm the director of the OTP at the Plymouth House of Corrections, and Dr. Gudas is our medical director there. I just wanted to know if you could talk a little bit more about the continuation of people when they're released, especially for like methadone clinics, since we're here to talk about methadone today. We find a lot of obstacles in both confirming people's doses. If they come to jail, if they miss even a few days before they come to jail because of the OTP regulations, a lot of the times we can't continue them. And then you mentioned like the ICE detainees too and federal detainees, and kind of what do those systems look like on the outside once people leave the environments that they're in?
Yeah, it's not easy, right? And I'm going to kind of answer that indirectly too, which in the context of eligibility, more coming in, I guess, but for patients who have take homes, that also qualifies them for recent treatment. So I'd like you guys to think about that for patients that you may know have some kind of a carceral history in the community setting, because that may influence their ability to continue care. For patients that are leaving, I want you to understand that they don't have a clinic to come back to either, right? But I don't know if that answered your question about the challenges of reentry. I mean, I'll also say around the challenges of reentry, there's huge complexities. And, we have an OTP and our own reentry staff trying to help. The jails often have their own, and then there's often outside entities. And it's kind of like the incident command system, if people are familiar with that, where there's too many cooks in the kitchen. We have the resources, but we can't always provide them to help with reentry. Other places, we just don't have the resources.
My name is Michael Horvath, and I'm a nurse practitioner at Essex County Correctional Facility, Gudas. And I just wanted to flesh out some of the barriers that we face in jail, which he did a good job covering, but the degree to which we have to go to. So I work in medical and in OTP. So I've been there since before the lawsuit. So there was no treatment for our patients, and the suffering was epic. Some of these people actually thanked us for the suffering because they're like, I'll never use again. Whether they did or not, I'm not sure. But we introduced the program. I got into the program because a corporate person walked up to me one day and said, they need help in MAT, so you start tomorrow. So that's how I got into MAT. I had already gotten my X waiver because I just wanted the 16 hours of credit. But so one of the things that we faced, like he was saying, was the diversion of medication. The diversion is huge. So whenever I am starting somebody on Suboxone and I do a urine drug screen, they're always already positive for butte because they're self-treating in the jail with the drugs that have been diverted and the drugs that have been smuggled in the man purse, or the jail purse, they call it. So there's a lot of it there. A lot of people who are actually being treated he talked about them diverting it to organizations where it's being sold to everybody else in the jail. But some of these people are being coerced and beaten and threatened, and their families are threatened outside of the jail to force them to divert. And sometimes they're pressured into getting off of methadone so that they can get Suboxone in order to provide it to whatever gang wants it so that they can sell it. We just introduced a new program where
Can I just
Oh, yeah, sure.
respond to the question,
Yeah.
the issue of diversion? So we've done some analyses looking at diversion,
Yeah.
and we only have 1 minute left. So I'm gonna take
Yep, that's fine.
liberty. So yeah, diversion is real. It happens. There are, we didn't really go into this today, but there are procedures that the facilities need to do in order to minimize that. One of the things that we have seen, though, however, is that when you have a well-run program and you treat everyone who needs it, the amount of diversion drops precipitously because the black market value of particularly buprenorphine goes pretty much to zero. It's like, why would you pay $40 or whatever for a strip if you can just go down to the, and the people who need it are people like you're describing, somebody who comes in who is self-treating. So if you're actually aggressively treating those folks and treating everyone who needs it, that issue of diversion really tends to dissipate quite quickly. And you're right. If you have a program where you just put somebody in the regular med line and you're just dosing them, then yes, you're going to see diversion. But you need to do mouth checks. You need to do other things to be sure that that those things don't happen. A lot of most of our facilities are doing that. I am hearing stories about other places around the country that are not investing the resources that you need to do this properly. That, I believe, puts this at risk, right? Because once you start to see deaths and diversion and other things, then that makes politicians and others very uncomfortable. So you really need to do this in the right way, but you need to aggressively treat everybody who needs it.
Add one thing real quick. So just really quickly, as far as I can tell, there are 4 reasons that people divert. One is that they don't like the amount or the frequency that we were giving it to them. 2, somebody's strong arming them, pressuring them to bring it back. 3, they're indigent, they don't have money and they need it. Or 4, they want to help a friend who's not in the program. And I am for expanding treatment of both of these modalities, but there are huge complexities about finding staff that are trained to really assess the people that need it. And as a counterpoint, it just has to be said that before these tools were brought in, there was a long precedent because of the safety and ease of getting buprenorphine into the jails and the fact that it is so potent that small amounts could be distributed very efficiently, that many of my patients' first dependency started in jail or prison with buprenorphine. They were not offered cannabis or alcohol or their psychotropic medications, and so they started self-medicating with the buprenorphine, and that dependency segued into fentanyl and led to stuff downstream. So the jails are aware of this, and they have a memory of a time where that was a drug of abuse in that environment. And so you have to counter that in many ways. Thank you.